Thank you for participating in today's webinar, which is brought to you by the Victorian Clinical Stroke Network. My name is Julie Smith, and I'm the project lead for the Clinical Network, and I'll be coordinating the webinar today. The network is very grateful to have Skye Coote, who is a stroke nurse practitioner, presenting on the mobile stroke ambulance, which is a really exciting initiative that has started recently in Victoria. We expect the webinar will run for around 60 minutes. The technology enables you to ask questions of the presenter throughout. Skye will do her best to answer the questions during her presentation. However, we will also allow for some time for her to come back to the questions at the end. At the end of the presentation, a short survey will appear on the screen. It should take less than a minute to complete. All responses will remain anonymous, but please take the time to answer them, as it really assists us to design future webinars to suit your needs. I'd also like to bring the attention to everybody just a change in how we communicate with the network. All of our, we'll be recently launching our network newsletter, so please take the time to register so you can keep in touch with what's happening across all the clinical networks. And finally, before we begin, I'd like to draw your attention to the general disclaimer that's on the screen now. This effectively states the views expressed in the webinar is that of the presenter. So on the behalf of the VSCN, I hope you enjoy this webinar, and I will hand over to Skye to begin.
Thanks, Julie. Thanks, everybody, for dialing in and taking the time. I'm sure that everybody is super busy. So, as Julie mentioned, I'm presenting on the Melbourne Mobile Stroke Unit. So I have no doubt that many of you will have heard about it, but it may still be a fairly new concept to some of you. So hopefully this will answer any questions that you have. And as Julie said, as we go, if you do have questions, please type them in. And if I haven't addressed them as we go, we'll answer them at the end. Okay, so this is the Melbourne Mobile Stroke Unit, and this is a project that was made possible thanks to the generous donation from a number of partner organisations that you can see on the bottom of the screen there, as well as some anonymous donors and philanthropists that have donated to it, which is lovely. In terms of our leads, this project is co-chaired by Professor Steve Davis and Jeff Donnan. My role is I'm the nursing coordinator, so I take care of all the nursing aspects and a lot of the administration, data custodian, and I work alongside Dr. Henry Zhao, who is our medical clinical coordinator. So let's start with the really obvious question of what the hell is an MSU? For a start, MSU is possibly the single worst acronym known to man for any medical project, but unfortunately we are stuck with it because it was actually not our term that we coined. It was already in existence when we got our ambulance. So just excuse me referring to a midstream urine sample as we go along. So a mobile stroke unit, or an MSU, is a fully equipped ambulance, and it's specialised specifically for stroke patients. And the way that we specialise it is that we have an onboard CT scanner. We also make sure that the crew is specialised for stroke. So essentially we're taking the hospital to the patient. So the background behind mobile stroke units, the first one actually began in Germany 10 years ago now. That's their one that you can see on the screen there. So they were very successful at treating patients in the pre-hospital setting, which made others sit up and take notice. They found that they definitely reduced the time to treatment, and they also increased the number of patients who were actually eligible for treatment. And because of the work that the people in Hamburg did, it led to a number of international models. So here are some of the vehicles that exist around the world. So let me just bring up my pointer. So this vehicle at the top is another mobile stroke unit that's in Germany. This one is in Berlin. It's called the SEMO. Top right is the University of Tennessee Memphis mobile stroke unit, and it's one of the largest ones. So you can see that it's a truck. Cleveland, India, UCLA, Houston. So there's a lot in America. There's also a number throughout the world. So this is a map taken from 2017. The blue dots are countries that had active mobile stroke units back in about February of last year, and the red triangles were countries that were actively looking at implementing. So when this was published, we were in the process stage of setting ours up, and we were hoping to be the first mobile stroke unit in the Southern Hemisphere, but you can see that Buenos Aires have got one, and then we were hoping to be the first in Australasia, but Bangkok got one. But if you just have a look at those blue dots, and now we look at the next screen, and you can see how many blue dots there are now. So this is 12 months later, so this is February of this year. So the mobile stroke unit is now not a unique project in the sense of, there's now about 18 in the world and many, many more coming. And if you look at places like Chicago, they've in fact got 2. New York have got 1, and they're planning on 2. UCLA and Los Angeles are planning for a second one. And certainly we know Melbourne could do with more than 1. So what does an MSU do? So what they found with these early mobile stroke units, when they looked at the data around it, was it definitely increased the amount of TPA that was used, so we're treating more patients. In Hamburg, they found that they halved the onset to TPA time, meaning they're treating patients far earlier, meaning that hopefully there is less stroke damage that's been done to their brain. In Berlin, they had a 600% increase in TPA in the golden hour. Now, traditionally, we've referred to the golden hour as our door to needle time. So when patients come into our hospital and we want to treat them within 60 minutes, so that golden hour. What's actually, because mobile stroke units, what's actually happening is that we're redefining the golden hour, and this is actually now being referred to as the first 60 minutes of stroke onset. So they've dramatically increased the amount of patients that are treated within that first hour after the stroke has started. Cleveland could show that there was a 45-minute decrease in time to clot retrieval, and Berlin also saw increased delivery of hemorrhagic stroke patients to neurosurgery. So the benefits are multi. So why do we want one? We really want one because we want ultra-early assessment and treatment, and as we said, more patients in that golden hour. So as we said, Germany showed a dramatic increase. So they went from 4% to 57% of patients treated in that golden hour within that first 60 minutes. And all of this is designed to reduce death and disability rates, because we all know how important time is. The other reason that we want an MSU is to provide for a good pre-hospital triage. By actually diagnosing patients in the field with what type of stroke they have, we can reduce into hospital transfers, and we can take them to the nearest appropriate hospital that offers the services that they require. Obviously, the sooner we can stabilise our patients and manage them, the better. And the MSU also is a novel platform for research trials, which is quite innovative. So this is probably familiar to a lot of you, but the theory behind all of this is time is brain. And Jeff Saver showed quite clearly in 2005 in large vessel occlusions, every minute we delay unblocking that vessel costs the brain 1.9 million brain cells. But time is also disability. So not only are we losing brain cells at a rapid rate, it actually then has an outcome effect on the patient. So every minute that we can save and we get back to TPA time saves 1.8 days of extra healthy life for that patient. So every 15 minutes is a month. Time is also life though, so for every 15-minute reduction in time to TPA, it's also associated with a 5% lower odds of mortality. So every minute that we can get TPA into patients faster, the better it is. We're going to reduce the amount of damage that's done to the brain. That's going to have a positive outcome effect, that we're going to have reduced death rates, we're going to have reduced dependency rates. So again, this graph is probably very familiar to all of you. So this is the odds ratio that shows us that why we want 4.5 hours for our TPA, because as we get to that point is where we actually cross our confidence interval and we actually start to lose benefit. But if you have a look at the graph starts at 90 minutes because that's usually where patients are being treated when they come to hospital. So by the time patients call an ambulance, recognise they're having a stroke, call an ambulance, the ambulance arrives, get them to hospital, we treat them. The earliest most hospitals can hope for is about 90 minutes. So what we want to do is actually look at what happens to that graph. If we can treat patients earlier, if we can treat patients in less than 90 minutes, and particularly in less than 60 minutes, we don't know what happens to this graph. This red line, does it sort of continue to just come up a little bit, or does it come up quite substantially, meaning the patients have got a far greater chance of having a modified Rankin score of 0 to 1 when treated with TPA. So, what we hope to see is this exponential increase to this curve, meaning, again, the faster we treat them, the better it is for the patient. The current workflow for a normal hospital looks like this. As we said before, somebody has, first of all, what we don't have on here is they have to actually recognise that there is a problem and decide that they actually want to call for help. So somebody has to call 000. An ambulance is then dispatched to them, and an average time for Ambulance Victoria is about 15 minutes from getting the job to actually getting to the patient. They then assess the patient, make a decision, and bring the patient to hospital. Depending on where the patient is and what time of day it is, that transport to hospital for metropolitan Melbourne is, somewhere between 15 and 30 minutes. It is ambulance protocol to bring the patient to the closest stroke centre, so they may be bypassing smaller peripheral hospitals that don't have any stroke services because they are to take them to a lysis centre, which is why this can be a little bit longer. Patients then arrive in our ED, we take them to the scanner, and then we treat them. So depending on whether you're a large volume centre or a smaller volume centre, what your stroke processes are, this process takes on average 30 to 60 minutes. And in fact, what we do know is data from the Stroke Foundation shows us that only about 30% of Australian hospitals can even achieve a door to needle time in 60 minutes. So this red treatment can be, quite delayed. So what the mobile stroke unit does is it brings that treatment down that graph. And we say treatment, we're predominantly talking about TPA, obviously, but this is any treatment. This is getting the patient to an ECR centre. This is getting the patient to neurosurge. This is actually beginning supportive therapy on the vehicle to actually stabilise the patient as well. So again, we still are relying on somebody calling 000. We're still relying on the mobile stroke unit getting to the patient. We've got similar dispatch times, but then we're doing the CT in the patient's driveway, and then we're treating them. Only after we've done that are we transporting them to hospital. So we're dramatically reducing that time to treatment as compared to a standard hospital model. So onto our vehicle, what have we actually got? So the Ambulance Victoria fleet is a Mercedes-Benz Sprinter vehicle is what the Ambulance Victoria uses throughout their entire fleet. So we have a 519 Sprinter. It's basically the largest of their fleet vehicles, so it's the biggest ambulance on the road. It's got a capacity for 5 seats, so we have 2 seats in the front for the paramedics, and then in the back we have the rest of the staff. We've got an integrated CT scanner, integrated telemedicine, meaning that when we don't have the doctor on board, we'll be able to have remote audiovisual input from the doctor. We have a point-of-care machine for INRs, and we obviously have standard ambulance medications, and we then have specialist stroke medications. So we do carry everything that a normal ambulance would carry in terms of medications. So this is what she looks like. So we're standing at the back of the vehicle here looking towards the front. So the driver's cabin is up behind this wall. There's our CT scanner. It motors forward on these silver tracks on the floor. So this is a standard ambulance striker stretcher. So we load the patient into here. We attach a headboard to the top of the stretcher, pop the patient on, slide them up, and then the scanner rolls forward over the top of the patient. So rather than a traditional CT model where the patient is on a bed that slides in and out, in this case it's the CT scanner that moves. Up on the left-hand side of the screen, we've got some computers here. This is our CT imaging that we use. You can see some sides of the seats. We've got drawers full of equipment, medications, etc. And on the next slide, this is looking backwards. You can't see it, but up the very top, as we're looking at left-hand side, there's also cupboards on the roof line that has a lot of our equipment as well. So 3 seats in the back. These seats, the base actually lifts up, and the ones on this side actually swivel so that the backs are against the side of the ambulance, which increases this walkway space to give us a little bit more room. Camera up here is our telemedicine camera, so when the doctor dials in, they can control the camera so that they can look down onto the patient. And to give you an idea of the size of the scanner, this is Fran, our radiographer, standing next to the scanner. So you can see that the hole is actually quite narrow. It's a very narrow borehole, meaning that we can't actually do neck imaging. So while we do a CT angiogram, it only is a circle of Willis because the patient's shoulders won't actually fit in the scanner. So the scanner is specific to doing CT brains. It's not going to do chests. It's not going to be useful for trauma. It is just because of the size of the hole. So these scanners were actually originally designed to be used in intensive care units for patients who were too unstable to move into the CT room. And for most of these patients, they were wanting head CTs, which is why they made this size, and obviously because they needed to then be portable to be wheeled into the intensive care unit. So they had to be not too big. And you can see here the little wheels that it motors forward on. So who's on board? We've got a crew of 5 at the moment. So we have 2 paramedics, and we have 1 advanced life support paramedic and 1 MICA paramedic. So if we do have the occasion that we do need advanced life support, we have a MICA paramedic on board so we can intubate patients. We can give drugs above and beyond what we would normally give as part of our stroke meds. My background is critical care, so I'm also an ALS critical care nurse, and our other staff ALS trained as well. We have a radiographer, as I said, stroke nurse, so this is an advanced practice role. And then we have a neurologist. Now, at the moment, the neurologist is on board, but the aim is long-term to actually move to a telemedicine model. So this will actually be a nurse-led telemedicine system, meaning the nurse will be the sole stroke expert who's actually on board the mobile stroke unit. So the neurologist will be in their office at the hospital, and we will ring them to say, right, we need you to dial in. So they can dial into the camera and the audio, and then they can actually communicate with the patient. The doctor's face does come up on one of the monitor screens that was also where we see our CT images, but from a practical perspective, the patient probably isn't going to be able to see the doctor, but they'll at least be able to hear the doctor talking to them, and most importantly, the doctor will be able to see the patient. So in these instances, the nurse will also act as intermediary to actually assist the patient in doing whatever it is that the doctor needs them to do if we're needing to look at specific assessments. So our CT scanner, it's an integrated Ceratom CT scanner, which is an 8-slice, and as I said, it does a non-contrast CT and circle of Willis CT angio. All of the scans that we do get sent back to the Royal Melbourne Hospital to our PACS system, and they get reported on by the radiologists here. If we're bringing patients to the Royal Melbourne, then we obviously have the CTs already in our system. If we're taking patients to a non-Royal Melbourne Hospital site, then we've actually got these USB wristbands. So we'll download their CT images onto these wristbands, pop the wristband on the patient, and the patient gets wheeled into hospital wearing their CT images. Radiology at the hospital then just has to take it off the patient and actually directly import it straight into their PACS system, and they're available for viewing. So the stroke medications that we carry, obviously we carry TPA. We've also got a number of BP medication that, as most of you would know, probably that's the second most common thing we treat patients with. So our first-line drug we use is actually nicardipine. So most hospitals would use labetalol as first-line, but in the States, nicardipine is used a lot more, and it's actually recommended as a joint first-line antihypertensive along with labetalol. But anecdotally, there was a lot more evidence to say that it seems to actually affect blood pressure faster, more smoothly, less trends to hypotension. You don't have the issues that you can have with labetalol being a beta blocker on patients who have cardiac issues, respiratory issues. Nicardipine is it's in a calcium channel class similar to amlodipine, so it doesn't tend to have the cardiac myocyte effects. So it very nicely brings down blood pressure. So we give that as a infusion via a 50 ml syringe. If we need to, we can give labetalol, and we also carry hydralazine. In terms of managing anticoagulation, we do carry idarosuzumab or Praxbine to reverse the bigatram. We also carry prothrombin X and vitamin K. We also have Keppra for seizures. The ambulance medication they carry Midaz. So if we do have a patient with a seizure, first line we'll give them midazolam. Second line we can give them Keppra if we feel that they need it or if they're in status. And we also carry Maxilom. And the ambulance carries Stemetil and ondansetron. So as I mentioned before, one of the reasons why we want a mobile stroke unit is it does provide a unique platform to actually conduct hyperacute stroke research trials. We have a number of trials that are going on at the moment. So we have 2 thrombolytic trials. One is Extend-IA TNK Part 2, which is comparing 0.25 milligrams per kilo of tenecteplase to 0.40 milligrams per kilo. So 0.25 is what was used in Extend-IA TNK Part 1. 0.4 is what is used to treat STEMIs currently in Ambulance Victoria. So we're really looking to see, can we get away with just using 1 dose? So this is a trial for large vessel occlusion. So if we do a CT angiogram and see LVO, we can enroll them into this trial. We also have TASTE-A, which is alteplase versus tenecteplase. And we have a hemorrhagic trial, which is STOP MSU, where we're giving either tranexamic acid or placebo. It is a double-blinded study. And this is for hemorrhagic stroke patients with a volume of less than 70 mL who are presenting to us within the first 2 hours. And the idea is just to try and stop that early hematoma growth. We've also got an observational study on board, which is collecting some biomarkers around stroke. So our operational protocol, we operate at the moment Monday to Friday, 8 a.m. till 6 p.m. So the paramedics and the nurses work 12-hour shifts. The radiographers split and they do an AM and a PM, and the doctors will either do split shifts or they'll do the whole thing. We are looking at increasing our hours in the future, but this is still early days and we need to see what the need is and where we're best sort of situated in terms of servicing that need. We are based at the Royal Melbourne Hospital, but we are jointly operated on a daily basis between Ambulance Victoria and the Royal Melbourne. So we have to have been integrated into the Ambulance Victoria systems because we get dispatched by them. So we are essentially an ambulance for all intents and purposes, but half of our staff obviously are Royal Melbourne Hospital staff, so there is that joint management. So the way we're dispatched is when somebody calls up 000 and they get a call taker and they go through their questions. If it falls into what is a code stroke code, the dispatcher would have normally sent an ambulance on as a code stroke. If it's within our catchment, which I'll show you on the next slide, then we also get dispatched. So we are dual dispatched. We are an additional resource on top of the ambulance that would have normally gone. And our code stroke policy is within 6 hours of onset. So a lot of mapping went into this very early on to see exactly where we were best to be operating. And there was a number of boundaries looked at, and we looked at it if we went to sort of a 15-kilometre radius around the hospital, and that would account for about 50% of the calls per day. In the end, it was decided that we should go to a 20-kilometre radius, which allows us to see about 75% of the code stroke calls. So if we look at that boundary on a satellite map, it's a 20-kilometre radius around the Royal Melbourne Hospital there. This catchment area is about has about 1.7 million people. And we've got the 2 state-designated ECR centres being the Royal Melbourne and Monash. Now, Monash is very slightly outside of our catchment, but that doesn't matter if we have patients that require ECR that are closest to Monash. That's where we go. So within this area, we've got 6 additional hospitals. So we've got Western Hospital Sunshine, the Northern, Austin, Box Hill, Alfred and St Vincent's as well. So obviously some of these hospitals have both neurosurgery and or ECR capabilities and others do not. So we've got a number of primary and comprehensive centres that we can take patients to. So as I said, we're dual dispatched with another ambulance. So when we get there, usually we're second on scene. Occasionally we'll turn up first or at the same time as the other ambulance, but usually somebody's beaten us to them. And so when we get there, the paramedics will give us a brief handover of what's going on, and then we obviously launch into what we need to do. So obviously, just the same as code stroke coming into your hospital, the main things that we need to do is our assessment of the patient. So what is the story, what's actually happened today, what's their NIH, what's their MRS, medications, past history, all the usual things. So pretty much what we need to do pretty quickly is make that decision of, are we going to scan this patient, yes or no? So we need to really just get enough information to make that first decision. From there, we start going into parallel tasks. So once we've really made that decision, then the ambulance officers usually are responsible for getting our IV cannula in. We take off some blood for biomarkers. We obviously test blood sugar, and if needs be, we'll test an INR if patients on warfarin. We also get them to coordinate patient extraction. So, we've been to patients that have been wedged in small bathrooms, that have been, upstairs with dense hemiplegia, and they're, second floor of a house. So they're really the experts in knowing how to extricate patients. So while they're doing all of that, we start sort of doing things like a more in-depth assessment, sorting out are there any contraindications to treatment, and obviously helping, wherever we need to. So to try and keep our times down, just like a standard code stroke, all of this has to happen in tandem. One of the big things that we need to do is there's a lot of education and explanations on scene, despite the fact that this was very well publicised through hospitals and Ambulance Victoria. A lot of the ambulance officers still don't really understand what it is that we're doing and what we're trying to achieve, and they can look at it and go, but we're 10 minutes from hospital, why are we standing around on scene for you to be able to do this? Why don't we just load? But they're not understanding, how important it is to reduce that time to diagnosis and treatment. Families are very taken aback. They don't understand why a second ambulance has turned up, and they see us take the patient out and load them, and like, so you're going to hospital, and we have to explain that actually no, we're doing scans in your driveway. Based on that, then we'll go to hospital. And also, we're keeping that other crew on scene for longer than normal, so we're waiting till the end of that scan to make a decision as to which one of us takes the patient and where the patient's going. So we have to make sure the other paramedics know exactly what's going on. The ambulance has to be level to scan, so we've got the ambulance has to be level to scan, so we've got stabilisers that have to go down. The patient's data has to be entered into the system just like for a standard CT, and we have to get the headboard attached to the stretcher. We then load the patient into the ambulance and then position them for CT. So this is obviously not a picture of the mobile stroke unit. This is obviously a stock picture, but you can see just how far up you actually need to get the patient off the bed or the stretcher to actually have enough room to bring the scanner down over their head to sort of the front end of the scanner actually touches basically the patient's shoulders. So we do actually have to get the patient quite a long way up the bed. So that does take all of us to do that. Once we've got them in position, we do a non-contrast scan. The doctor then reviews the scan and makes a decision whether or not we're going to do the CTA. If we have done a CTA, then obviously they review that, and then based obviously on all of that information, we then make a treatment decision and initiate treatment. Once we've finished the scan, we've got to reposition the patient down out of that headboard and back onto the stretcher, and we've actually got to prepare the ambulance for transport if we're taking the patient. Otherwise, we then have to take the patient back out and we put them into the other ambulance. So this means stabilising the stretcher because we've actually had the stretcher in an unusual position. It's not, we have to actually raise it so that the patient's head is at the right height for the scan. So we've got to bring it back down. We've got to make sure that it's locked in. We've got to stow the CT scanner, make that decision on which hospital we're going to, what is the most appropriate hospital for this patient, and then do our normal pre-hospital notification. So what happens with this is we follow standard channels that the ambulance officers will notify the emergency department as normal, but we also give, where possible, a stroke-to-stroke handover. We're obviously going to monitor the patient en route, and then when we get to hospital, we obviously hand over and have documentation to do. So when we come to treatment, what we can do is obviously thrombolyse patients. Now we're giving TPA in a syringe driver. We draw up the first 50 mils only. So if we are coming to your hospital, as part of your pre-hospital notification, you will get told how much additional TPA we're going to draw up. The reason we do this is because usually the patients are only partway through their dose by the time they get to hospital. If we walk in with a second syringe of the residual dose of TPA and say, well, we've made this up, Most hospitals are not going to accept that, and they're going to want to drop their own to make sure that it's the right drug, right dose, etc., to follow the 5 rights of drug administration. So TPA being so expensive, we don't want to waste it, so we get hospitals to draw it up if needs be. If patients are eligible, we'll enrol them in one of the thrombolytic trials. We'll obviously manage their BP, and if we need to, we can reverse the bigger tram prior to giving thrombolysis, which we've done on 3 occasions so far. We've given itolizumab for ischemic stroke patients and then lysed them. If the patient's having a bleed, obviously we're going to monitor their blood pressure and manage that. Again, we can reverse any anticoagulation that's on board with either itolizumab or prothrombin X and vitamin K. And if they fit criteria, we can enrol them into the STOP MSU trial. Because we are a standard ambulance, we can obviously manage seizures. We have occasionally needed to sedate patients very lightly to keep them still for the scanner. You think that normal hospital scanner beds are quite narrow. Ours is even narrower, so they often get a little bit agitated, and it's not very comfortable, the headboard under their shoulders. And obviously some stroke patients are very slightly agitated. Antiemetics we give a lot of to keep them from vomiting mid-scan. And we can manage airways if we need to with either endotracheal tubes or laryngeal masks. And we've actually intubated a number of patients, particularly large bleeds, that we can then intubate them and then safely scan them. So one of our big roles, as well as obviously just treating patients, and this has actually become more apparent as time's gone on, is the role of pre-hospital triage. So normal ambulance dispatch criteria is they go to a stroke, they diagnose it as a stroke, they go to their closest licensed hospital, because obviously until now you can't determine if the patient's a bleed or an ischemic stroke. But within the ischemic stroke, obviously there's very large benefit to having a diagnosed large vessel occlusion rather than a normal smaller clot somewhere that can't be retrieved. Monash and the Royal Melbourne, as we said, is the statewide designated centres for referrals, but Alfred, St Vincent's, Austin, all obviously do clot retrieval as well. So, they need to have, if we can get patients to those hospitals, that's a benefit. It's going to save significant time. So that pre-hospital triage, as I said, has become more and more obvious of, or more apparent of how much that role is actually needed to say, this is a large vessel occlusion, therefore our closest ECR centre is X, as opposed to just our closest lysis centre. Same thing applies, obviously, if they're a bleed, we want to go to the closest neurosurgical centre. So I don't know which hospitals you're working at, but I've worked at 2 large volume centres that have a lot of code strokes, and the code stroke team can be likened to a pack of wolves descending on this poor patient who's sitting somewhat terrified on a ambulance stretcher. So the other benefit of this pre-hospital triage is not only if we've got a stroke patient of getting them to the right hospital, but if it's not a stroke, is actually making the code stroke team not be activated needlessly. So by diagnosing patients with a migraine or a seizure that might have otherwise been called in as a code stroke, we're saving hospital staff. When we're looking at code stroke, you're talking about ED nursing, ED medical, ED clerks, medical imaging, your code stroke nurses, your stroke team, everybody that's involved in a code stroke. If we can save patients going in that aren't a code stroke, then we're keeping them on the ward, seeing patients, doing whatever else they're doing on the day. So that's basically what we do. So now the question is, how are we going with doing it? So our initial results, we went live on November 20th last year. So these results I pulled together a couple of weeks ago. So at that time we had 540 call-outs, and just over half of those were cancelled prior to arrival. So this happens when another ambulance, the first ambulance, gets to the patient before us. They assess the patient and say, not a stroke, so they'll actually stand us down, which is great because it means that we're free to go to another patient. So of the patients that we have attended, half of them end up being stroke or a TIA, and this number increases to 61% if we look at other neuroemergencies like seizures, brain tumours, etc. Of the patients that we see, we scan half of them with a non-contrast and a quarter of them go on to have a CT angiogram. We've given 24 TPA dose or thrombolysis doses. Some of these have been tenecteplase as part of the trials. So this means that 1 in every 10 patients that we get to see is getting treated. The big number that we obviously always look at is what is the percentage of ischemic stroke patients who present within 4.5 hours, and we're treating 39% of those, which is a very large number. And as we've talked about before, the golden hour, really pleasingly, we can see that that's starting to come up. So we've actually treated 17% of our patients, so almost 1 in 5 are getting treated within that first 60 minutes of stroke starting. Now, if you compare that to a standard sort of hospital data, most hospitals, even in your large volumes, are probably looking at about 2 to 3%, so very large increase in there. And if we look at that first 90 minutes, because we don't have that data on that odds ratio slide that I showed you earlier, we're actually at 38%. So thrombectomy, we've had 21 thrombectomy patients, well, 21 patients we've referred for thrombectomy. Obviously, we're not yet, we don't have the technology yet to put Peter Mitchell or Bernard Yan in the back of an ambulance with a angio suite and actually do thrombectomy on the road, but we've referred 21 patients for thrombectomy, which is 20% of all of our ischemic stroke patients. What's pleasing is that over half of these patients actually go direct to angio on our arrival. So depending on what we see on the scan, we get to hospital, they're not going into emergency, they're not going via CT, they're actually going straight up on the ambulance stretcher into angio, which is dramatically reducing their groin puncture time. So 44% of our thrombolyzed patients are referred for ECR. So one of our other goals was to reduce inter-hospital transfers by making sure that the patients are getting to the most appropriate hospital for their stroke condition in the first instance. And we've had 21 bypasses so far, which is 10% of all of our attended patients and 16% of all of our strokes. So that's quite a number. So 16% of our strokes would have gone to a hospital that then needed to later transfer them. There's been a lot of work done around door-in, door-out times or DIDO times, and recent data shows that even in large volume centres that do this with some regularity, it can take up to 2 hours to actually, from the time patients get to you, you scan, you diagnose them as a large vessel occlusion, you treat them if needs be, you get another ambulance, you reload them and get them back out the door, can be 2 hours. So that's not including then the transfer time to the next hospital, but literally just the first hospital getting from the time they get the patient to turning around and sending them back on their way. So that's a very large time saver that we're saving for those patients if we're actually reducing that inter-hospital transfer. So time metrics. So it's taking us on average about 17 minutes to get to patients, which is similar to a standard ambulance. You can see that our range is up to 44 minutes, and that's because while we operate within a 20-kilometre radius of the hospital, if we have a crew who actually gets on the radio and says, I've got a patient with a dense right hemi and aphasia, onset time was 2 hours ago, witness, can I have the mobile stroke unit? Then we will go further afield. So our 20 kilometres is basically for standard dispatch via normal call takers, but we can respond to anywhere. So obviously the further afield we go, the longer it takes us to get there. Scene to CT is about 21 minutes with a range of 5 to 77 minutes. The 77 minutes is those patients that have needed to be intubated prior to scanning, because obviously airway takes precedence. One of the questions we get asked is, why is our median scene to CT so long? People thought that it would be a lot quicker, but one of the unrecognised delays was patient extrication. So the Australian average, if you have a look, this is all based on the 2017 Stroke Foundation clinical audit data. The Australian average for door to CT is 27 minutes. So we're not much faster, but if you think when a patient comes to you at the hospital, they may or may not have a cannula in, but they're on the stretcher, you meet them at the door, you verify that they are who they are, that we've got an onset time, that we've got no contraindications to going to the scanner, and you wheel them straight through. When we get there, the patient quite frequently is still somewhere quite difficult to get them out of. We're quite often arriving and the other paramedic crew have only just arrived, so the story is still fairly much undifferentiated at that stage. So we don't even know if this is a stroke and we want to scan. Then we've actually got to get them out. So that's where a lot of our time comes from. So scene to needle median is 40 minutes with a range of 23 to 80, and that's very favourably compares to the Australian average of 72. And onset to needle 103 compared to the Australian average of 150. And as you can see, we do have onset to needle in that sort of 50-minute mark to actually have that golden hour. So another question that was posed to us when we looked at ranges as compared to sort of standard hospital ranges and Australian average ranges is we're still treating patients, within the same range. If you actually look at the range, it's not dissimilar. The medians can be, depending on what month you're looking at, can be quite similar. And the question was posed, well, what are we really saving? Is there any point if you're really treating patients? Door to needle is great, scene to CT, all that thing is great, but really we all know what we need to look at is that onset to needle. And if we're treating patients at within the same time frame, where's the benefit? But that's actually not comparing apples to apples, because what actually happens is we might be treating a number of patients within that 4 to 4.5 hour mark, but we're treating them in the community. If they needed to be loaded to hospital, get into a hospital, and then go through the standard procedure, they would be outside the 4.5 hours. So yes, in some patients it's taking us as long to treat, but what we're actually doing is increasing the percentage of patients that were actually eligible for treatment. Now the bottom line is alarm to needle. So this is a new time metric that's starting to come out because of mobile stroke units. So while we really compare our scene to needle to your door to needle, they're not quite the same because, as I said, patient extrication is a very significant delay for us. So alarm to needle is actually truthfully comparing patient groups. So alarm is from the time that the ambulance is dispatched through to the time of treatment. So this allows, ultimately, when we start to collect this data in hospitals, will allow direct comparison to actually show us the real-time saving that the mobile stroke unit produces. And as I said, with our onset to needle, 17% are thrombolyzed within that golden hour. So what does the future hold? More MSUs. So modelling would suggest that we need probably about 1 per million population. So Melbourne could really do with probably 3 or 4 scattered around the centre. That's what we'd like to see. That's what we hope to happen. We need the scanner people to continue working on the scanners and produce more advanced portable scanners that are capable of doing more, faster, higher quality images, etc. Better field, in-field diagnostics, more research. But the big thing that's really come out of this is while we're thrombolysing 39% of patients who present within 4.5 hours, our major reason for not thrombolysing patients remains that they're presenting too late. So this is all great, but at the end of the day, what we still need is somebody to call the ambulance in the first place. So we are still hindered by that step. So we need everybody to be far more aware of the FAST campaign, far more aware of stroke, and to obviously call us sooner. Thank you. That's all. So I don't know if there's any questions.
Thanks, Skye. That was a really fabulous presentation, and it was really great to hear about the amazing innovation that the mobile stroke ambulance is, and I guess some of the early results. It doesn't sound as though there were too many questions that came up throughout the presentation, but obviously we have a little bit of time there at the moment, and so please feel free to add some via the text box on the bottom of the screen.
Okay, so I've just seen one question come up. Now, apologies if it starts to get a little bit noisy around me. The helicopter's just about to land on the roof, so apologies for the noise. What additional complications do you have with bariatric patients? So yes, we actually have had a few patients who we haven't been able to scan. So they're either kyphotic, so they're, because of the size of the hole, if they are, say, too kyphotic or too obese, we just can't fit them in. We've had 1 or 2 patients who the radiographer actually, very gently pushes down on the tip of their nose as the scanner comes over their head to make sure that they're actually fitting. So if the stretcher itself is not so much of a problem. I think the stretchers are weighted to something like 250 kilos. It's quite a lot. Beyond that, the ambulance actually has their bariatric ambulance. But if they're too big, it's more around the size of the CT hole, and will we actually get them in there? So what we've got to, as much as we get very disappointed if there are patients that we can't scan and we can't treat, what we have to remember is that this is an additional service, and that if worst case scenario, what they're going to do is go to hospital and actually have standard of care. Any plans for regional areas? So yes and no. So this was a Steve Davis and Jeff Donham put together the proposal for this. They worked with the partners to actually, get the money. It's obviously a multi-million-dollar project. So at the moment there's money for one, but what we're really hoping to show is that this is of benefit, and therefore, we can put pressure on the government to say we need more of these, and we absolutely need them in a regional area. We get asked a lot as to why it was in Melbourne, why not put it in a regional area, and the answer is it had to go somewhere first. And at the end of the day, Steve and Jeff made it happen, so it sits with us. But as I said, it just had to start somewhere. Next question, is there an age restriction? Only around the TPA, so we don't want to scan children. We don't actually have paediatric protocols for scanning on board because we're not going to thrombolyse paediatrics, so we deliberately haven't set ourselves up from that perspective. So certainly no upper range, but we wouldn't respond to paediatric patients. Next question, when the MSU was being implemented, we were told that the receiving hospital patient would need to replace the alteplase used on the MSU. Is this still the case? So one of our ongoing costs with this, obviously the truck itself is a multi-million-dollar vehicle, but one of the largest ongoing costs is the use of alteplase, because what we stock our alteplase from the Royal Melbourne Hospital pharmacy supply, and then we're thrombolysing patients that would normally have been thrombolised at one of 8 different hospitals, and they would normally be paying for it. So we're essentially covering a large portion of the state of Metropolitan Melbourne's TPA use. So the original thought was that yes, what we would do is when we came into hospital, we would actually just swap back an ampule. That is still happening, but not as a ampule for ampule. It actually now gets invoiced through to pharmacy departments. Has there been any cost analysis done? That's ongoing. So yes, part of this is absolutely looking at cost effectiveness, and we're still in the middle of collecting and collating all of that data. So hopefully we'll have something soon. Any other questions? Are there plans to implement the MSU in other states? Yes, well, I obviously can't speak for other states, but I would imagine that there is, that other states would want to do this. So, as I said, I can't speak for them, but there's certainly been a lot of interest from the other states, and hopefully they will also do it as well. No other questions?
Well, if there's no other questions, I'd just like to take the opportunity to thank you, Skye, once again. If you do think of any further questions, please feel free to email them to me. And if Skye doesn't mind, I can forward them on to her. Mm-hmm. And so I think that just about wraps it up for today. So the next webinar will be presented in a month's time by Coralie English, and we'll communicate that via the website. So thank you very much.
Thanks for having me.